even more. This is a very interesting article. Herman Duterlo, now he is 80, one of the best orthodontics around the world. He works in Holland, and you know that in Holland they have a lot of class 2 division 1 malocclusion. So he devoted his beautiful professional life to correcting more or less class 2 division 1 malocclusion. He found, at the end of his career, he said, 52% of my patients in my office presented complications, a lot of complications. TMJ complication, instability, crowding, complication, too many. So this is the end. What should we do in front of a severe class 2 division 1 malocclusion, severe skeletal pattern? What should we do? In front of a nice girl, very young, 7 years of age, with a retrognatic mandible, a class 2 malocclusion, a long face, and a retrognatic maxilla. If you look at the maxilla, he is a little bit retrognatic compared to the nose. What would you do if she were your daughter? She's a nice girl, but the class 2 is evident. Would you use an activator? Would you use extraoral traction? What goals would you define before starting treatment? Okay, this is the malocclusion, crowding for the lateral incisors. Once again, a diastema, frenum on the upper between the upper incisors, central incisors, narrow maxilla, of course. You have the crowding, you have the class 2, skeletal malocclusion. This is the occlusion, this is the profile, this is the tracing. A skeletal class 2, 5 degrees, A and B, short mandible, and also the maxilla is not so well positioned sagittally. What would you do? What are the goals of treatment? The overjet, the occlusion. Do you want to place the molars in class 1? The profile, do you want to improve the profile by stimulating the mandibular growth? Would you improve the smile? The gummy smile is very gummy. The mother didn't like the gummy smile and the diastema. The crowding, the mother is not worried about the crowding because she doesn't see a lot of crowding, but in 1 year she will have a lot of crowding because the upper incisor, the upper lateral incisor will erupt crowded. We know it and we have to tell it to the mother. And when would you plan to fix all these problems? So the question is, what are the goals of treatment? Do you want to fix all these problems, only some, and when? I have very clear ideas in my head, and I hope you also have it now. I decided to do a limited treatment only to fix the upper jaw problems, crowding, the diastema, and the gummy smile. So I placed a rapid partal expander on the decidus molars. I placed a wire with a little bit of risk because I moved also the lateral incisor, but the mother insisted to have very nice displaced incisors. treatment was very short, only in the upper jaw. At the end of treatment, I made a splint. I was very careful in checking the eruption path of the permanent canines. So I did an upper alignment. The occlusion wasn't correct. She still is in class 2. I decided not to correct the occlusion because whatever I would have done, I would have moved back the maxilla. And in my opinion, this would have been a worsening of the smile, a worsening of the profile. Maybe I would have been able to get a couple of millimeters of mandibular extra length, extra growth. But the cost I had to pay would have been to move back the maxilla. So I decided not to work on the sagittal plane. I did a limited treatment only on the upper jaw to fix the smile. Of course, at the end of early treatment, the smile is very wide because she has the size of smile of an adult in the face of a kid. Once again, is it an anticipation of growth? But in class 2, the smile is very wide. In a girl, too much. In a woman, is correct. Didn't touch the class 2 malocclusion, nothing. Here is the normal growth. No, here is the normal growth during treatment. I didn't do anything on the sagittal plane. She is growing not only vertically, but also sagittally, so it's not a bad grower. Is not a beautiful grower, but is a counterclockwise direction of growth. 2 years after, she is in permanent dentition in the upper jaw. Splint is still there because the splint is very useful if she had a traumatic injury on the incisor. The splint is a little bit of like a mouth guard. Now the smile is much more in balance with the face, not because the smile is smaller, but because the face is bigger. She is growing. So now there is a good proportion. What did I do to improve the gummy smile? Nothing. Because the gummy smile, when she was 7 years of age, was only a matter of passive eruption. If you wait in the ears, the marginal gingiva will retract. So I didn't I didn't do any gingivectomy. I didn't do any frenectomy, nothing. And here is 2 more years after. And here you see that now the smile is beautiful. Is beautiful. Why is beautiful? Because I didn't move back the maxilla. I didn't correct the class 2. She still is in class 2. I removed the splint and the teeth are quite stable. No need to do any frenectomy. The frenum disappeared itself. I didn't touch the soft tissue, nothing. I didn't touch the soft tissue. I didn't cut, I didn't do anything to improve the exposure of the teeth and the papilla. No retention, 7 years after early treatment, quite stable. Do you want to see the face? She is growing now. Nice hair, nice overall appearance of the face, but what about the profile? Wow! Not only the upper jaw, the maxilla is retrognatic. You see it very well here, of course. You see the nasolabial angle very open. And you see that the maxilla ideally should be 1 centimeter forward. she is growing very well, but also the nose is growing, and this is very predictable. You can imagine if I would have pushed back the maxilla, how she would be now. Look at the profile without any orthodontic treatment. So, if orthodontic treatment can only move back the maxilla or move back the maxilla together with 2 millimeters of stimulation of the lower jaw, you can imagine how the profile would look like if I would have done a class 2 functional or what else treatment, orthopedic treatment. She still is in class 2, she doesn't care, mandibular growth, facial growth was very favorable, but she still is a class 2. She still is retrognatic in the maxilla and in the mandible. What can we do? Only worsen this kind of profile if we work during growth. So much better a limited treatment, let her occlusion in class 2 in order to achieve at least a good smile. Okay, this is the end of the end of growth. Now she is waiting for the phase 2 to be done at the end of growth, when I will have the possibility to ask her how she wants to be treated, and she will tell me what she wants to do when she will be at the end of growth. Actually, she already is at the end of growth. She is almost 30 years of age, and she told me that she doesn't want to do any phase 2. She is happy like that. So in my opinion, this is a treatment with a beautiful cost-benefit ratio, very effective, because his primary goal, his priority, her expectation was the smile. And we know from the literature that even if she is in class 2, there is no correlation between a class 2 and the risk of having temporomandibular disorders. So, as long as we know, in 2021, we can live in class 2, we can live in class 3, we can survive very well, we are healthy if we have an anterior crossbite, we are healthy if you have a class 2 malocclusion. So is this time nowadays, it is time to change our way of thinking about what are the real goals of orthodontics. The goal of orthodontics is not to create a class 1 malocclusion. The goal of orthodontics is to improve the quality of life of the patient, but even more, from my point of view, the goal of orthodontic treatment is, first of all, to prevent a damage to the patient, to prevent not only an overtreatment, but to prevent a worsening of the health of the patient. And believe me, there are so many among our colleagues who create a lot of damages every day. I am a patient of an orthodontist who created a lot of damages to me. So my first priority when I go inside this door every morning is not to do a miracle, is not to improve the teeth, is not only to fix the malocclusion. My first priority is not to do any overtreatment, any damage to my patient. All my patients are healthy. I don't have to create a illness into them. So this patient at the end of growth was not without any problem. She was in class 2, but she also had a COCR discrepancy. She had some noises in the joint. She is a singer. She couldn't open the mouth very much sometimes because she used the mouth very much. And even if she had a slight temporomandibular disorders, this is not an indication to an orthodontic treatment, to a surgical treatment. I just gave her a biplane, and she is without any symptoms now. Look at the normal growth. She doesn't care about the profile. She's interested in the smile, and the smile is acceptable. The temporomandibular disorders can be kept under control with a biplane. Doing an orthodontic surgical treatment in a patient with temporomandibular disorders is also very risky. You need a very good surgeon. She had what she wanted. She has what she wanted, a nice smile. I had what I wanted, efficient treatment, and effective. She is happy, she has a nice smile, she has a functional problem not probably related to the malocclusion, and I prevented an overtreatment, so I'm also very happy. So nowadays, in front of a patient like this, what I do is just to do a good diagnosis and a good treatment plan before deciding what appliance to use in order to fix the open bite. My first goal is to do a diagnosis and a treatment plan. And my first priority is to prevent an overtreatment. Then, of course, if we decide to do something, I have to do it at the best we can. If it is a difficult treatment with surgery, okay, we have to do it well. I'm ready. But it's not mandatory. So this is an open bite, full class 2, retrognatic mandible, hyperdivergent pattern of growth. Probably he will grow in a counterclockwise direction, incisors slightly protruded. He never had traumatic injury until now. The open bite could be a problem because of the tongue, because of the lips. I didn't send him to a speech therapist. I didn't care about the tongue. I was a little bit scared about the possibility to have a little bit of crowding in the upper jaw. And I knew at that time from the literature that an open bite in the mixed dentition could improve spontaneously without any kind of treatment, just correcting the bad habits. And the bad habit of this patient was the lip incompetence. So I was hoping that, as was published in the past, the open bite will self-correct during the mixed dentition stage, and I just ask him to work on the lips and to keep the lips closed. We know, and these are numbers of my office, that open bite in the mixed dentition tends to self-correct. So I checked 116 consecutive patients treated by me, same means Marco Rosa, and we are doing this prospective clinical trial, still in progress. I checked this patient who all showed an open bite at the beginning of the observation period. Open bite means that I had a negative overbite, not only on the central incisors, but also on the lateral incisor, and in some patients also on the canine. It's not so easy to define what is an open bite in the first transitional period. And I didn't treat the open bite at all. I treated the palate, but not the open bite. And as you see, in this case, there is a good overbite at the end of the observation time. There is a good overbite at the end of the observation period. In this patient, I didn't treat the bite, I didn't treat the tongue, nothing. In 92% of my patients, anterior open bite, self-corrected. 92% among 116 patients. In all these patients, I corrected the overbite. In some of them, actually, I used some appliances, but never with the goal of correcting the overbite. The appliances were to treat other features, crossbite, crowding, something like that, more or less expanders. So let's go back to our patient, and how would you plan what to do in this patient, knowing that there is a possibility which varies from 70 to 90% to achieve a self-correction during the mixed dentition without any kind of treatment? I would wait, of course, and this is what I did in this patient. I didn't do no treatment at all. I just advised him to improve the lip competence. This means that they have to work on the lips a little bit, and the minimum is remember that with the lips closed, they are more cute, more nice, more cute in the face, much better. They are more healthy because the bacteria don't go in, and for sure they will need of less orthodontic treatment because the lips closed keep the incisors back. The kids understand very well these 3 points. And if you explain to the kids how convenient it is to stay with the lips closed, they write it something on the end in order to remember that it is better for them to keep the lips closed. It's only a matter of remembering. You don't need a speech therapist. It's only a matter of don't forget you are more cute with the lips closed. So this is what happened in 2 years in this patient, the open bite closed. This is when he was 14, almost 15 years of age. As you see, still he is in class 2, skeletal class 2, but the protrusion improved because of the lips closed. This is the normal growth. This is the normal growth. Still in class 2, lips are a little bit closer. Now, of course, you know that you cannot expect a better mandibular position with a functional treatment. 2 millimeters is nothing. This is the occlusion, still in class 2, very acceptable by the patient. There is a slight COCR discrepancy. This is not the best time to do a treatment because, in my opinion, an orthodontic treatment can only worsen the smile, can only worsen the profile. Of course, the right treatment would be could be a surgical approach, but not for sure not when he is 14. And then if we decide to do surgery, it will be because he wants to do surgery. So I wait, and if there is a COCR discrepancy, perhaps at the end of growth he will decide to do surgery. I do a diagnosis and I place a mouth guard in order to maintain a good health of the condyles during the peak of growth until age 18, 19, when he will decide whether to have a treatment or not. So when he is 19, the TMD didn't appear, he has no problem in the temporomandibular disorders. I asked to him, what do you want to do? Do you want a treatment? Now is the best time to have a treatment. Now we can do what you want. We can fix the mandible, we can fix the TMJ problem, we can fix the occlusion, you can be treated with extraction of the upper premolars. Of course, you go back with the incisor. It's not the best, but you can do it. You can do surgery. You can go on and wearing your bite plane. You can do what you want. And he said to me, and if I stay like this, of course, there is a minimal risk of having a worsening of the temporomandibular disorders, but if you go on using the bite, it will not appear. Even more, if you use the bite, the teeth will not age, will not become crowded and abraded. So I think about it. And he decided not to do any treatment, of course. So the phase 2 still is to be decided. And what we will do, it will be decided by him. So this is the end of the morning. We have been talking about class 3, open bite, prediction of growth. What can we do to manipulate growth in the class 3, in the class 2? And now it's time for lunch for you. I hope I was able to give you some advice. My goal is to provide to you not information about a new appliance. Appliances are very important. All the appliances are working well. My goal is to open your eyes on a new future in orthodontics with new goals and new eyes in order to see the malocclusion in a different way. And this will be the beginning of a new era where we understand that we must not treat the class 2 or the class 3. We must treat the patient, which is much more difficult, much more beautiful, much more exciting for us than treating only the occlusion. What I want you to remember once again, and this is my take-home message, is that both in the class 3 and in the class 2 even more, we are not interested on 2 millimeters more or less. If to get 2 millimeters more, or in the maxilla in the class 3, in the mandible in the class 3, in the class 2, we have to strive years and years and years and maybe create damages to the patient. We are not interested. We are interested in taking care of the patients. So now you go. I wish you to enjoy your meal, to enjoy your lunch. We will be together in 1 hour, I think, around in 1 hour and 15 minutes. In Italy, it will be 1 o'clock. In Moscow, 2 o'clock. I don't know who is connected to me in streaming. Maybe there is a different time. I want to wish an enjoyable meal also to them. So see you in 1 hour. Bye. After the lunch, we will go on talking about early treatment, about growing patient, about missing teeth, missing premolar, impacted molar, and missing incisors and impacted canine. Will be an afternoon where we will not talk about growth, we will talk about, we will not talk about occlusion, we will talk about space closure and how to manage impacted and missing teeth. So, see you in 1 hour.